One thing the book does not cover well is this topic. So this is a topic outside of the book, but I think it's a very critical topic because it's something that we deal with a lot in the operating room. We actually resuscitate more people more aggressively than anybody else in the hospital ever will. Okay, and there's a lot of things that people don't understand in medicine, even though they're ICU doctors. You can see the difference between an internal medicine doctor and an anesthesia, critical care, or surgical ICU doctor. It makes a huge difference how they resuscitate. If you were in internal medicine and you would tell somebody, give them 3 liters of fluid, they'd look at you like you're crazy. Versus in trauma, that's something you would do normally and not even consider it as a problem. Shock is something that unfortunately for many, many years was just thought as a simple concept as just blood pressure problems. And it wasn't until the invention of Levophed, or we also call it Levomdead, where shock became a rediscussion, because when you gave somebody Levophed, you can actually maintain them and have a totally normal blood pressure. But they were all dead within 24 hours if you gave them high enough doses of it. Okay, so Levophed got a very, very bad name for a very long time until people finally began to understand that shock is really not a discussion about blood pressure, but it's actually a discussion of perfusion. So the points of discussion is we're going to go over the definition of what shock is. And really, if you actually read about shock, like I do, I read a lot about it. It interests me a lot because of my background. That you get many different definitions. And you can go all the way down to the cellular level, and which we want to talk about briefly, which is called the process of shock. And then we're going to go into the different classification systems, and that's where the confusion sometimes comes in. And determination, the form, how you determine the form of shock the patient's in, and then the different treatment modalities that you may actually encounter. What is basically shock is not this hypotension. Okay, so patients may actually appear totally normotensive and still be in shock. Okay, so really, shock is really a syndrome of inadequate perfusion, and it tends to be a systemic disorder, and it's at a cellular level. Once you initiate a certain what's called a final common pathway, you will eventually cause organ regional blood flow disturbances, and you will actually cause organs to begin to die. Individual cells in that organ begin to pass and develop what's called apoptosis. The reason for them developing that is because it has a decreased cellular oxygenation, eventual ATP depletion, and they activate the lysosomal suicidal pathway, which causes eventual cell death and damage. And if you do enough cell damage, you start causing multiple organ system failure, which is a real big problem with shock. If you can address it quickly enough and get the person out of the shock in the first golden hour, usually you don't see any of these long-term effects. But if you start not reversing somebody's shock in the first 3 hours, there's a very good chance that the person will develop end organ stage dysfunction within 24 to 72 hours. What you see is pathophysiology of shock is its inadequate perfusion. The cellular swelling that if you look at microscopically is that the cells actually begin to swell. The endoplasmic reticulum shows the first signs of stress, and what looks like an endoplasmic reticulum, if you're looking at muscle, is the SR. So the SR in the muscle is what shows the sign of stress. It is the one that begins to swell. If you've ever seen somebody who develops ischemia, let's say of a muscle, you should feel the way the leg will feel. Let's say they get ischemia to the leg. If you squeeze the leg, the calf, does it feel soft? Does anybody remember? It feels like a rock. It's hard, right? It's hard. The reason it's hard is because the cells begin to swell. And it begins to swell from inside out and puts pressure around the surrounding cells themselves. And it can be so hard, the swelling, that it will develop what's called a compartment syndrome. And to alleviate that, we actually will do sclerotomies, which would cut the skin open to let the excessive drainage and pressure be able to reperfuse the other cells around it, so you don't get cellular death of the whole muscle. You might get big segments of dying, but not the whole thing will die. And will the person lose or atrophy that muscle as a consequence? The answer is yes. And depending on how fast you got to it, it'll determine how much function they're going to get back. Will they get some of it back? Yes. And they will, a lot of times, will be functional again. But you will notice that if you look at these people's their legs afterwards, after they survive the event, their cell mass is decreased. And if you look at the actual leg, you'll see the discrepancy in size after the disease process is sort of reversed. What happens is the endoplasmic reticulum of the SR releases intracellular calcium and leads to an increase in lysosomal release as well as mitochondrial disruption, which then causes ATP production to falter and eventually cell death. So it's a whole cascade event. Now, what's really interesting is if you're really interested in this kind of topic, you should read in the library. There's a new form of treatment called hypothermic management, okay, which we're taking patients that have developed cardiac arrest in the field, and we're putting them in a hypothermic state for about 24 to 72 hours, depending on which protocol you want to use. And the actual book goes into this whole cellular mechanism. There's like a whole 2 chapters on it. So if you're interested in this kind of shock kind of state, it's a good read. It's a little bit too much for what you guys need right now. Just to understand that there's a whole cellular process that's taking place, and there's a whole set of all sorts of releasers and all sorts of kinds of chemicals that are being released by the cells during this process. Yes? Hypothermia? Yes, hypothermia, if you get somebody down to low temperatures, when you rewarm them, they're more likely to develop VTAC and VFib. So in that sense, it is dangerous. But the reason that we're inducing hypothermia is to increase cellular survival, especially the brain. We know that some of these mechanisms are shut down by hypothermia. Okay? So these chemical mediators that are increased cellular swelling and cause more cellular damage are inhibited by inducing a person into hypothermia. But the risk, again, is if you get them too hypothermic, you may cause them to rewarm hypothermia and develop VTAC and VFib. So there is concerns. There's risk. But it's an innovative therapy if you're trying to protect the brain. Okay? And they've actually had significant improvements. A lot of people that arrest in the field and they're not gotten to quickly enough suffer irreversible brain damage. And these new treatments apparently have ameliorated the effects significantly, enough that it's becoming it's almost people consider it should be considered a standard therapy now. It is very expensive, as you can imagine. These people are going to go immediately into the intensive care unit. They require hypothermic management, including possibly putting on cardiopulmonary bypass to do it. So it's not something that's necessarily cheap or without some other associated complications too. But it's something interesting to read if you're interested in that area. And you might end up taking care of those people in the future because they might need some kind of surgical procedure where you need to have to give them anesthesia. So if you're into one of those centers, you might see that. The other thing that you get a response is because of the increased levels of catecholamines, you get a neurohumoral response. The catecholamines will cause an increase in heart rate, contractility, preload cardiac output, and venous arterial tone. So you see a whole effect from the shock state. It's sometimes delayed, sometimes not necessarily, but sometimes you'll see it take up to 6 to 12 hours before you see the full adrenal mechanism kick in to cause the effects that we normally will see in long-term shock. The neuroendocrine response is also important. You get activation by the actual catecholamines and stress will increase the levels of adrenocorticotropic hormone, which increases the aldosterone activity. That alone will increase sodium retention, water retention. Glucocorticoids are also important and also get activated. Growth hormone is also activated. And you get also modulation of renal function by the antidiuretic hormone, which increases water retention, and things like catecholamines, which increases renin release and also lead to an increase in aldosterone levels. Overall, pretty much all stress states increase aldosterone levels, okay, which increases your water retention. And if you're a person that's already in failure, it may not be the best thing. Okay, if you have somebody with ascites and you develop at high levels of stress hormones, you're going to get worsening ascites if that person continues to increase their aldosterone secretion. So some of these mechanisms are great and adaptive for an acute state, but when it becomes a chronic issue, it becomes maladaptive and becomes pathological. And sometimes medications that we use basically shut down the system and try to rectify it and make it go back to a more normal state. One of the things that pathophysiology of shock is that once you get inadequate cellular perfusion, the cell goes anaerobic. Okay? And what basically happens is the tricyclic acid pathway becomes inhibited. Okay? If you have no more cytochrome oxidase, which is the oxidative phosphorylation taking place, then you have to go anaerobic. So pyruvate can't not go into the TCA cycle to be consumed and used for energy. Instead, pyruvate begins to accumulate in your cells. And the cells are not going to be happy about it because it forms into pyruvic acid, which is very dangerous for the cell. So instead, it wants to convert it into something that it can handle, which is lactate. Okay? Lactate is a byproduct to increase NADH levels again. So it takes your NADH and converts it back to NAD so it can go back to the glucose pathway and continue at least production of some ATP. Is it effective? The answer is very little no, but it's still producing at least a little bit of ATP. Okay? And the lactate then is put into the bloodstream, where the liver handles 80% of it. So lactic acidosis is going to be an issue that's going to go to the bloodstream, and then it's going to go to the liver. Okay? If you get liver dysfunction, guess what happens? The lactic acidosis persists for prolonged periods of time. So you've got to be really careful with somebody who's in hepatic shock or any kind of hepatic problems. If you develop a lactic acidosis, it's going to be very, very difficult to reverse in these individuals. One of the things about lactic acidosis, it's a marker. It doesn't mean that if you treat it, it's going to make it go away. You've got to identify the cause. Why is a person hypoperfusing? If I give you bicarb, the lactic acidosis will be masked in the sense that the metabolic acidosis will normalize. Okay? The problem is I'm not really addressing what's causing the lactic acidosis. So unless I don't give people bicarb unless their pH falls below 7.20. That's my general rule. Okay? I try to identify the source, and then I start treating it, and then I check my serial blood gases and see if my pH is becoming more normal. Okay? Some places have the actual ability to actually draw lactate levels, which is great. In most places like Naples, where we actually send it out to another hospital, it takes 8 to 15 hours to get the results back. So that makes the test expensive and useless. Okay? By the time 8 and 12 hours are done, the patient's either dead or getting better. Okay? So you're wasting money. Okay? But if you're working in a level 1 trauma center where they have lactate levels readily available, it's a good way to spend $100 and figure out exactly what's going on. Okay? But again, consider the data. Is it coming back fast enough you're making use of it? Then do it. If not, don't waste the money. Immediate concerns is that the lactate levels is an indicator of organ perfusion, which is, of course, due to perfusion pressure, vascular resistance. This lactate is a byproduct of metabolism for this anaerobic. Will get into the bloodstream, eventually gets down to the bloodstream. And so identify the cause, don't just treat the symptoms. Shock affects organs differently. One of the things that I always look for when I talk to people, when I go to a trauma center, when I used to work there, was I always said hello to them and would try to see if they knew where they were at. I had one guy that was 24 years old and came in, wasn't really drinking or anything like that, fell off a motorcycle, had his helmet on, survived the fall and everything else, and the guy came in completely lucid, talking to us like nothing was going on. He said, "You feel anything?" "Nah, it's just my belly hurts a little bit." And then he went from being completely lucid, within 15 minutes, start getting confused. And I said, "You know where you're at?" He said, "No." He thought he was out with his girlfriend. Okay? And it just got progressively worse, the confusion. And the blood pressure at that point was 120/65, and the heart rate was 85. So we thought, hey, this guy's normal. Got good blood pressure, good heart rate. What we didn't know was the guy was a long-distance runner, and his normal resting heart rate was 52. Okay? So a heart rate of 86 was a state of shock for that kid. Okay? And he's intensely vasoconstricted because he's young. Okay? So the confusion was what set us off that he was having some kind of perfusion problem. And sure enough, within 20 minutes later, all of a sudden his blood pressure went from 120 to 70, and then he went unconscious. That quick. And he had a ruptured spleen, which we went out to the operating room to save his life. Had 2.5 liters of blood in his belly. Okay, so you've got to sort of pay attention. The brain tells you what's going on. The same thing happens when you're working in OB, which is considered the other shock trauma center where we work at pretty much daily. Okay, when women get hypoperfusing, the first thing they tell you is they're going to vomit. Okay, if you see that, you give the ephedrine right now. Give the pressor, because by the time you cycle the blood pressure, the person is going to be vomiting or is going to be more profoundly hypotensive. So just give them 10 of ephedrine, usually to boost their pressure back up, and everything all of a sudden, they say, I don't feel nauseous anymore. It's like, yeah. Nausea is a sign of hypotension as well, and as well as confusion. If the person rolls up their eyes on you and doesn't know where they're at and acts completely crazy, you better check the blood pressure or make sure the pulse is there. Okay? Because it could just be, or the person appears to have a seizure. That's pretty bad. That usually means the blood pressure has gone to 0, and the seizure is actually from a syncopal episode from lack of perfusion to the brain. So those are things that you've got to pick up on. Heart is brain is very sensitive to perfusion issues. Also, brain will not last more than 5 minutes without perfusion. So once you see no blood flow goes to the brain, you got 5 minutes before you restart it again. At that point, it becomes progressively irreversible. Okay. The heart is a little bit more resistant. It can take up to 15 minutes for it to be permanently damaged. Okay, but you got 15 minutes. That's not a very long time. The reason for the heart is it has such a high extraction rate. The big problems you have with the heart we see in shock is usually tachycardia, some form of arrhythmia. PVCs usually become evident. Okay, usually you can see sometimes loss of contractility, which is, you can see drops in blood pressure as a consequence of that. Lungs, depending on what kind of form of shock you're talking about, will either stay dry or wet, and we'll talk about that in a minute. Kidneys will also show signs of stress by lacking production in urine. But as long as you're not anuric, it really doesn't tell you anything. If you're anuric, which means that you have no urine at all, you're in a very bad spot. Okay? You don't want to be there for long. Okay? If you're putting out some urine, it doesn't really tell you how good perfusion is getting to the kidney. You're just telling you that you're getting something there. But it doesn't mean that the kidneys won't get stressed even with that. Liver, pancreas, and the GI tract are also of a concern because until recently we didn't understand that if you shock the GI tract, one of the first things that happens is the mucosal wall loses its integrity. And when you lose mucosal integrity, the thing that will translocate is everything that lives inside your GI tract, which is all the bacteria, yeast, whatever's living in your colon or your small bowel. Usually the small bowel has very low amounts of bacteria in it. The actually lowest amount of bacteria in your whole GI tract is in your stomach. The low acidity levels in your stomach basically kills almost everything. So if you have to say which one is, if I was going to perforate something, stomach would be the best thing to perforate. Except, of course, it causes acid burns inside your belly. But besides that, it has the lowest bacterial count. Small bowel, we actually repair with gunshot wounds or stab wounds through it. As long as we close it up, not a big problem. Most people don't develop septic shock. Right colon, which is the ascending colon, bacterial counts go up considerably, but they're not so bad that you can't repair that side. But as soon as you go to the transverse colon, bacterial counts go through the roof. And if you got a left-sided injury, which is a descending colon injury or a sigmoid colon injury, we do a Hartmann's procedure. Okay? The reason we do the Hartmann's procedure is that if we try to anastomose it together without an unprepped bowel, it's just going to get infected and break down on you. You have a disaster in your hands. So everything after the transverse colon this way, we cut, bring it to the skin, 6 months, come back together. Okay? You're asking for it. I've seen people try it, and I've seen every time it's been a disaster. So the books are right about it. Just do a diverting colostomy and move on. Okay? But what happens is if you're not even in the shock state, the mucosal breakdown gets in. It gets to be a problem. Bacterial translocates, gets into your liver because of the portal circulation. The liver will handle so many bacteria per minute, okay, which uses what's called Kupffer cells, which are specialized white cells that are embedded in the liver, and they'll eat up. They're macrophages that eat up the bacteria. But if you get high enough bacterial count, it will actually translocate, get past the liver, and get to what next big organ? Lungs. So you'll develop ARDS. So, and that's what we were not picking up. People that were getting into profound shock were getting into GI shock, and then they were developing ARDS 24 hours later. And what it was from is from the bacterial translocation. Okay? So that's another thing to think about. The other thing that blood, of course, is inflammatory mediators that get sent down the stream, as well as alterations in platelet. It can also sequester in the lungs. It can also induce multiple organ system damage as a consequence. So there's 3 kinds of shock. And the way I look at shock, I always break them down into 3 points. And I was trying to figure out which one is it that I'm dealing with. Hypovolemic shock, cardiogenic shock, or what we call mixed or neurogenic shock, or vasogenic shock. Okay? Those are the 3. Okay? If you keep those simple in your head, you will be very effective in taking care of people that develop shock. In vasogenic shock, in hypovolemic shock, you have 2 forms, which we'll talk about in detail, which is hemorrhagic and non-hemorrhagic, which means that you're losing volume in the blood vessels. That's what hypovolemic shock is. Cardiogenic shock is basically anything that impairs the heart from working properly. And they break it down into different kinds, which I will go into more detail, which is contractile dysfunction, impedance to ventricular outflow, as well as filling, valvular failures, dysrhythmias, and myocardial rupture. Myocardial rupture is usually you don't have to worry about because usually they're pretty dead pretty quick. So not something you have to worry about very often. As for mixed or vasogenic shock, that one you do have to worry about because you can get into situations where you get a person develop neural shock on you. You can get in situations where the person's full-blown sepsis in the operating room. You can also get toxic shock syndromes, anaphylaxis, drug overdose, or trauma without hypovolemia, which is burns and things like that. So I'm going to go into each one of these specifically and go into more detail. Hypovolemic shock can be broken down into 2 kinds. Hemorrhagic shock is pretty visible and evident most of the time because somebody's bleeding all over the floor. If they're internally hemorrhaging, that's a little bit more difficult to pick up, but usually you can pick it up pretty quick because the person all of a sudden loses their color. You can actually see somebody who looks normally tan and they'll turn white on you. Okay? And usually it's a very bad sign. The way I look at it is look at the capillary beds in the hands, look at the mouth. If the person's mouth opens up and the tongue is white, you're in big trouble. Hemoglobin's down to 4 or 2, okay, or less. So the things that I look for right away is look at nail beds. If the nail beds are red, hemoglobin's greater than 8. Okay, if the nail beds are white, then go to conjunctiva. Okay, if you see the conjunctiva is white, then the hemoglobin is 6 or less. Okay, and if you open up the mouth and the actual tongue is white, you're down to less than 4 hemoglobin. Now, you don't have to believe me. One of you will call me a few years from now, or maybe 6 months from now, or 7 months. Dr. Nolan, I saw the white tongue. I'm going, yeah. Okay. So it's absolutely true. Okay. When you see it, you'll be going like, crap, I wish he hadn't known that. So, but it's a really bad sign. Okay. The person will get into hypovolemic shock. It could be from GI, hemorrhaging. And it can be massive. You can lose a lot of blood from a peptic ulcer. Usually you'll know it because the smell in the room. So you pick up, everybody knows what a GI bleeder smells like. Of course, trauma, internal bleeding. It could be from blunt, long bone, ruptured aorta, retroperitoneal hemorrhage. We'll talk all about that in trauma in coexisting component. We'll actually have about 6 weeks talking about different forms of hypovolemic shock. So we're going to get into this a lot more. You also have non-hemorrhagic shock, which is the most common cause of hypovolemic shock, believe it or not. And most people think, the most common cause of hypovolemic shock is hemorrhage, and the answer is no. The most common cause is actually diarrhea. Diarrheal diseases kill more people and more humans in the world than any other disease. Okay, still to this day. Okay, most of the time it's bacterial dysentery or some kind of bacteria that's not really conducive to your GI tract, and you start losing massive amounts of volume inside. You know. And it's really easy to treat. All you need to do is get an IV bag, hook it up to somebody, give them fluid transfusions, and that's it. You're not giving them blood at all, you're just giving them fluids. But in most underdeveloped countries, it actually is not available, and people will die as a consequence. Renal losses can also be a small fraction, just excessive diuretic effects, osmotic diuresis or DI. And the other ones are things like burns, which is pretty evident. Pancreatitis. This is what Gray-Turner sign looks like. This is somebody who has hemorrhagic pancreatitis. This is this is I went from the non-hemorrhagic to the hemorrhagic. Sorry, sort of. People asked me this about a year ago, what Gray Turner's sign was, and that's what it is. You get this flank hemorrhaging, and that's actually the pancreas dissolving itself and causing hemorrhaging retroperitoneal. These people develop a severe peritonitis, and they lose massive amounts of volume inside their belly. They develop ascites a lot of times. If you actually open up the belly and look inside, it actually looks white, and I've seen it. It's what's called saponification. The pancreatic enzymes will take the internal fat of your omentum and begin to break it down and form soap out of it. So it actually is pretty interesting how destructive pancreatic fluids can be. Remember, the pancreas has not only endocrine but also exocrine functions as well. As for cardiogenic shock, we sort of went through this in the last few lectures, so I'm going to go through this kind of quickly. Things that are contractile dysfunctions such as cardiomyopathies and MIs, we already talked about that. The impedance of ventricular outflow are things that you have to sort of think about, or intrinsic or extrinsic. The intrinsic are things like diseases that are intrinsic to the heart, such as aortic stenosis or IHSS, which is idiopathic hypertrophic subaortic stenosis. And the ones that are extrinsic are things that are being, let's say, affecting the pulmonary artery or the aorta, things like pulmonary emboli that can cause a massive extrinsic ventricular outflow to the right ventricle. Pulmonary hypertension with cor pulmonalis can also cause that in the right ventricle. On the left side of it, the aortic dissections can do this, okay, usually, which is you'll tear the aorta and then you'll get a significant impedance effects on your ventricular outflow. How about filling? That's the other side of it. If you impede ventricular filling in the sense of the left side, which is intrinsic, which could be mitral stenosis. You can also have atrial myxomas, which is usually found in the left atrium more so than the right, and you have atrial thrombus. The extrinsic ones that we will talk about hopefully later on this afternoon, or just finishing up today, will be tamponade, which is pericardial tamponade, and a restrictive pericarditis. As for valvular failures, things like MR or AI can be acute and very severe. Usually AS is not something that acutely occurs, so you have a lot of compliance or time for ventricle to hypertrophy. So usually it's not something that cures acutely, versus AI can occur very acutely from aortic dissection, which I've always read about until I saw it about 2 years ago. It was rather impressive when I saw it. The actual valve was completely disrupted from the aortic dissection, and we actually replace the aortic valve and the aorta, and the patient actually walked out of the hospital like 4 days later. It was pretty amazing. The guy was eating steak the next morning. It was like amazing. It was disgusting. 54 years old, and I usually never took care of, we usually take care of people like that and they don't survive it. This guy was 54 years old, and he decided to show his son that he could still lift 300 pounds chest pressed. And he definitely did it. He did 300-pound chest press, but he ruptured his aorta in the process. So, not a good thing. So, maybe not the best idea. Most people that have myocardial rupture usually don't become a problem for us because, like I said, they die. I've had some people actually rupture on induction, so that could be a problem as well. The traumatic ones, you can actually do a life-saving maneuvers such as thoracotomies to open up their chest and put your fingers in their heart to keep them alive. That is possible to do, but it's just a rare event that you actually get to do that. As for vasogenic shock, that's when you get inappropriate vasodilation of the actual sympathetic side. So the thoracolumbar area, remember we talked about before, is what's the control mechanism of the actual vasotone of the sympathetic drive. So if you lose that, such as in basically neurogenic shock, okay, you can cause extreme vasodilation to take place all of a sudden. And even though the heart's working just fine, there's just not enough volume available to pump all of that extra area. So you get a severe hypotensive shock. Neurojection shock, which can be so severe that they will actually induce any systolic state. Okay, sometimes that'll happen. The other things that will also cause vasogenic shock, which will be inappropriate vasodilation taking place, could be from toxic metabolites who are releasing things like in sepsis or toxic shock syndrome, or from things like slow-releasing substance of anaphylaxis or histamine in massive doses, such as an anaphylaxis. Okay, and drug overdoses can also, of course, if you give an inappropriate drug to somebody or somebody's taking a drug overdose, may also induce vasogenic shock. and trauma without hypovolemia, which is the last one, which is actual burns. Clinical recognition of these different disease states is the first thing you want to look at is look at the neck veins. That's the first thing I actually do is when I look at somebody that's in profound shock is I look at their neck veins. If I see their neck veins are giantly dilated and huge, that indicates usually right ventricular failure, okay, or pulmonary embolus. Okay? So those are pretty quick that I've got a distended neck vein. If I see flat veins, okay, that usually indicates hypovolemia, low volume states, or vasogenic shock. Okay? So those are the two ones that how rapidly I can break it down, okay, quickly in my mind what's going on. Okay? Then you want to assess the patient in their standard format and make sure you assess their airway, breathing, circulation. Remember, don't just treat the symptoms, identify the cause. You've got to figure out what the cause of it is before you start beginning to go crazy and treating all this stuff, and you may inappropriately make a mistake. Okay? I had a person who came in, and this is how you keep thinking like this. I was working in the ICU. The lady was 70 years old, 75 years old. Came in, the ER doc said, oh, she's having an MI. She had ST segment changes. So, okay, we're treating her like an MI. And, an MI patient usually develops left ventricular failure and their veins get distended, right? So they usually will expect to see the person's neck veins get huge. And hers were flat, completely flat. And I'm looking at her like, this doesn't make sense. I don't like what I'm looking at here. I spent for about 45 minutes trying to figure out what was going on. And I said, what is really going on? Listen to the heart, and all of a sudden I had a new murmur. I had a new diastolic murmur, which wasn't there before, about an hour later. So I said, well, I'm going to get an echo because I don't like because at that point I couldn't figure out what was going on. The numbers didn't make sense. Put in a swan in this woman, the PA numbers were low, CVP was low, but with that she had a giant amount of MR as well as AI. So I said, what's going on? So what I did next was I did an echo and found out she had aortic dissection. So she went from an MI, which she was having an MI because she was dissecting into the coronaries. She got put together and shipped downtown for the open heart surgeons to take care of her. So she survived it, did okay. But this is the thing, you've got to figure out what the problem is, not just start treating and not understand what's going on. Okay? Central nervous system, like I talked to you about before, you get decreased perfusion. If you go into syncopal, that's usually very bad because at that point you're under-perfusing the brain. Look for pinpoint pupils in case a person's narcotic overdose. There's a lot of people that are doing illegal substances out there, so you got to really consider that as a common ailment, unfortunately. Circulatory-wise, look for the heart, see if the person's tachycardic, usually indicates adrenergic stimulation. Or in decreased contractility, that's always a tip-off. If you have a decrease in stroke volume, the way cardiac output is maintained is by increasing heart rate. The other thing you may see is other dysrhythmias, it's just in coronary ischemia, hypotension from decreased contractility, and then new murmurs as well. So you've got to look at the whole system and try to figure out what's going on. Systemic-wise, if you have hypotension, you've got to identify it from decreased SVR, decreased venous return. If you have decreased jugular venous pressures, which is, again, two things I did indicate to you before, hypovolemia, decreased venous return, or mixed vasogenic shock. Increased JVP is from usually right heart failure, which is overall, what's the number one cause of right heart failure? Left heart failure, okay? So yeah, that's why I usually pick it up. Now, if you ever have right heart failure that's isolated, what will you hear in the lungs? They will be absolutely dry. Okay, that's how you know that you have isolated right ventricular failure versus you have combined left with right ventricular failure. If you see, as soon as you see the neck veins distend, what do you have? Right-sided heart failure. That's the number one thing you have. Okay, but do you have left? And the answer is, listen to the lungs. If the lungs sound wet, you've got combined. If it sounds dry, then you've got isolated right ventricular failure. Right ventricular failure is easier to treat than left ventricular failure, because left ventricular failure causes multiple organ system damage, versus right-sided failure causes more vascular congestion in the liver and ascites at times and peripheral edema. But that sometimes won't kill you as fast as left ventricular failure will. Make sure you check for peripheral pulses. Make sure you don't have coarctation and dissections going on, which is one thing I forgot to do this in this lady when I was actually doing her exam. I didn't check her pulses in her extremities. When I checked her pulses in her lower extremities, they felt weak. And the upper extremity, one side was really strong, and the other side was weak. So the dissection was going down the descending aorta, but the ascending portion of it was also dissecting, which is why it involved the aortic, but did not involve the one going to the right hand. So the right subclavian artery was intact. So different pulses in different situations. Okay. Respiratory, this is what I was talking about, versus wet or lung. Wet lungs, which means you'll get rales. You'll still hear an S3 with both failures, okay, but you get more prominently with a left-sided heart failure. You will get left ventricular failure, and sepsis will also indicate wet lungs, versus a dry with no breath sounds that will sound normal. Basically, there's no evidence of pulmonary edema. This could be hypovolemic shock, right ventricular failure, or vasogenic edema. Okay, vasogenic edema, if you wait long enough, will wet the lungs. Okay, but it takes time. Okay, it's something that you're not going to hear initially. Okay, in full-blown anaphylaxis, you're going to hear wheezing, but you're not going to hear vasogenic edema. So you're not going to get, crackles at the bases. A person will develop tachypnea with left-sided heart failure because the lung water increases. So the person develops pulmonary edema. You get respiratory muscle fatigue eventually, sepsis and acidosis. And of course, cyanosis is pretty prevalent in whatever disease that doesn't get enough perfusion to the lungs. PEs can be very frankly with very prominent cyanosis, and as well as congestive heart failure. So you can't normally pick it up just with desaturations. Renal oliguria, it just means that you have still can have decreased perfusion. If you go, the biggest concern is are you having afferent arterial vasoconstriction from high levels of epinephrine? If you are, make sure you're avoiding any use of non-steroidal anti-inflammatories such as Toradol. Skin, I always look for cold, clammy skin. One of the things that I shake hands with patients or I hold their hands, I'm also being nice because I want to make sure that the person understands that they've got human beings taking care of them and the person cares. But the holding the hands also gives me information as to if the person is in shock. I've had people with normal blood pressures and their hands are ice cold, and everybody's not worried, and I start jumping up and down because I am worried. The person's hands are so cold that you can no longer see perfusion. That's a bad sign. That means that whatever pressures you're giving way too much. Usually at that point we start backing off on the pressures and start giving more blood or whatever else we need to give at that time. It indicates overstimulation of the sympathetic system and too much vasoconstriction. On the other hand, I always look for lactic acidosis, usually by not normally drawing lactic acid levels. So instead I draw pH. That's why almost everybody that's in shock, I put an A line in, simply because I'm going to draw serial blood gases and serial pHs on them every 6 hours until I know that the acidosis is reversed. And I'm pretty aggressive about it. I don't let anybody stay in acidosis more than 6 to 8 hours. Okay, so at that point they've already drawn true blood gases, and it's not. And sometimes it's on every hour until you see you get reversal of the acidosis. So I'm very aggressive about it because I know the longer you stay in acidosis, the more profound the shock is becoming, and more likelihood that you're going to get end organ failure. So rapid resuscitation is very important at that point. It's not the time you should go to sleep. That's why you just need to sit up, and if you're in the operating room, you just never stop resuscitating that person until you get them back to normal. I had one patient that came to us that was a pH of 6.95, had been that way for 3 hours in the ICU, and their whole treatment plan had been to call us to make sure that we were ready in the operating room. The patient got no A line, no central line, blood pressure was 65 over 25, and the heart rate was 130, okay? And that's what we got. Here, he's stable, he'll do fine. Yeah, okay? Well, he bought an A-line, he bought a quad lumen, he bought 2 cortices, he then bought blood gases, which we did immediately, then he got intubated, so he had all these lines put in while he was awake. But he's not currently awake, he's kind of out of it. His blood pressure is 60. Okay, got him intubated, we resuscitated him with 10 units of blood, 20 units of FFP, I don't know how many units. Sometimes we gave him a little bit of platelets. Gave him so many amps of bicarb, reversed the acidosis. The guy came back with a pH of 7.35 which was an 8-hour operation. And his hemoglobin came back at 14. And you know what the biggest complaint was? You over-resuscitated the patient. I almost started laughing at that point, but you'll see people do crazy stuff like that. They'll drop you off a disaster, and when you bring them back with a hemoglobin of 14, they'll say, you overdid it. Okay, thank you. All right. And sure enough, the hemoglobin the next morning was what? 10. It redistributes. Okay? So everything starts shifting still. So it's, you're just amazed. But it never ends. And you're only as good as your last anesthetic, trust me. So do the best you can every day, and that's all you can do. One of the things that systemic manifestations is very common is, and the one I want you to really hit on hard is metabolic acidosis. If you're in shock, a person has metabolic acidosis, that person is in shock until you determine otherwise. You've got to figure out what's causing the metabolic acidosis. Could it be a poisoning? Yes. It could be some other sources? Yes. But if it's a lactic acidosis, it's a metabolic acidosis due to shock. I personally do not believe in blood pressure cuffs at that point because I put A-lines in everybody. Everybody buys an A-line that's in shock. Okay? I don't believe that you should use a blood pressure cuff at that point. You need the extra information for the blood gas to determine what's going on. Okay? So it's worthwhile to put an A-line in people. Okay? The risk of getting an A-line infection is infinitesimally small in comparison to any other line you'll ever put in anybody. So when people tell you, well, that's a higher risk, that's BS. Okay? It really is. Okay? Just take good care of it, keep it clean, and put it in properly, and you shouldn't have any problems. Systemic manifestations, we already sort of talked about this as well. One of the things that you'll see is sometimes you'll see seizures and weakness, which is something I don't necessarily always talk about, but pay attention that the person has multiple problems usually when they develop acidosis. It's also a form of shock. So you can just put symptoms of shock as the same as symptoms of acidosis. Initial management is where we become important in the sense that airway, breathing, and circulation goes in that order. Okay? If you have an airway issue, you immediately intubate and secure the airway, period. Okay? It doesn't matter what the circulatory system is doing. If you have somebody and you address the circulatory problem and you're not addressing the airway and they vomit and they then die of an aspiration death, you made a big mistake. Okay? That's why it's ABC, airway, breathing, circulation, in that order, always. Okay? The only where you don't follow that order is if you go into VTAC or VFib. That's not, VFib's always unstable. VTAC, if it's unstable, you immediately go to defibrillate, period. Okay? Everything else, we pretty much have to go through the ABCs. Some of us will use what's called SMART protocol, which is what I do, which is I stabilize as rapidly as possible. During this time, I monitor them to the nth degree, of course, reassess them again, review again, and then treat. And the most important part is the first, the in-between part, which is the assess and the review. The assess review means that you are constantly reassessing what you're doing. You don't just start doing things and then sort of lose a sight of what's going on. Okay? I'll give you an example of how we lost sight of sometimes of things that were going on. We had a young man who came in. He was messing around with somebody else's wife, and the guy came into the room and decided to take a knife to him and put a stiletto blade through his heart, through his sternum, all the way through his back. Okay, and so we all sort of paid attention to the knife. About 20 minutes into the trauma alert, after we're trying to figure out, this guy was still awake talking to us, and we knew the guy had to go back to the operating room. We had him only on the side because we couldn't roll him on his back because the blade was in the way. So we finally figured out, well, we could roll him on his back by putting two gurneys together and separate them a little bit, and then we put the blade in between. So that's how we got him to lay back on his back. Okay, and then the nurses who said, well, we asked him to put in a Foley because we're going off the operating room right away. And they said, well, we're missing something down here, doctor. And we'd missed it for 30 minutes. He was missing his penis. The guy had taken the pliers and pulled it off. So we had to send the paramedics back to the field to find it. Okay, and we tried to reimplant it later on. So it didn't work very well because we waited a little bit too long. Okay, So it's a way of sort of reminding you, don't forget the big picture, okay? Look at the whole thing. Look at the whole body. Don't just concentrate on the initial thing that sort of jumps out at you, okay? Things will surprise you in the trauma base, okay? That's what reassessment's for. So that funny thing should actually remind you in the back of your mind, oh, it's very serious. It was sad. The guy did survive, but his other friend did not. So, initial assessment, ABCs. When to institute mechanical ventilation is basically full shock. You need to intubate them and support them immediately. We found that survivability increases significantly if you intubate early. There's less risk of aspiration, more likely to maintain cerebral perfusion. So in absence of full shock, then assess the gas exchange, work of breathing, and is the patient able to maintain a patent airway. If they don't have any of those properly, you intubate them right away. So we tend to be aggressive. I never take anybody to the operating room that I think that's going to be in shock and put a spinal in them. They get intubated immediately. Okay, you do not mess and play regional anesthesia with these people. Okay, you do that and you're going to get burned. Okay, what will happen is you go into profound shock. Now the person loses consciousness, and now you got to deal with an airway with also a hypotensive event. Not something you want to do. So when you have patients that are OB, that are hemorrhaging massively, and they tell you, well, can you do a spinal? And you go, oh, no, this one's getting intubated because I know they're going to be in profound shock here in a minute. Okay, so that's not the ones you want to do a spinal in, cause a sympathectomy on them and lose all your tone and not have a blood pressure after that. So don't kill the patient because you like doing regional. Okay, you sort of got to find a balance. Okay. Treatment of hypotension is vasopressors, intravascular fluid resuscitation, and I'm not a real fan of putting people in Trendelenburg unless it's temporizing. If you want to do it in the first 10 minutes, I'm okay with that, but after 10 minutes, you better put them flat. In 10 minutes after you put somebody in severe Trendelenburg, you're going to cause carotid vasodilation to take place, and the whole body is going to go into more profound shock. So please don't do that. Okay? They've known that all the way back since World War II. The studies were done, and unfortunately for us, it never got passed on. And if you look at the actual most military drawings before World War II or right after World War II, all the way up to recent, they would actually take the gurney and put the person in Trendelenburg, and they usually would find the patients were dead 20 or 30 minutes later. What they were reducing is a more profound shock. Versus the Germans understood, they did the physiology studies on it, they would raise the legs only on their patients. And the new forms of treatment of shock, what do they tell you to do? Raise the leg only, not put the head down below the heart, okay, which induces that vagal, not vagal response, but it causes the baroreceptor response. IV access is key. Central line is really early, but depends on what kind of problem you're having. If you're having problems with volume, then you better put a cordis in, okay, which is something you can resuscitate quickly with. A central line is basically useless for resuscitation. If you have a choice between a peripheral IV, a 14-gauge IV, and a central line, take the 14-gauge IV. You're going to be able to resuscitate somebody more rapidly. So if you want some resuscitation from hemorrhagic or hypovolemic shock, put a cordis in their neck or a subclavian. And then put a central line after that if you want to for medications. So really a central line's for meds. So if you're a nurse and you love central lines, you know what? That's great. You should be happy with it because that's the kind of thing you'd use in the ICU. But in the operating room, it's a worthless tool. It's if you're resuscitating. You need something big, okay? Because you got to remember, surgeon puts big holes in things, and you better have something big to put it back in with, okay? If you're trying to push in fluid through a little catheter that's this long versus it's this short and it's big, you take the bigger and thicker one because it's going to be more effective than the thin, long central line, which is a nightmare. I've seen people try to resuscitate people through the quad lumens, and you fail miserably all the time. Okay, you can actually shear the blood cells because you're pushing it through rapidly through this these large length catheters, so resistance goes way up. And you'll see that your lines will rupture sometimes when you're trying to do that. That's really not good. It's like getting blood everywhere. Everybody gets an A-line, and the first thing we'll talk about in trauma will show you how to set up for resuscitation aggressively. Hemodynamic profiles is important variables to ascertain shock is cardiac output, and things that you want to look at is you look at the preload by looking at the PA occlusion pressure versus CVP. The afterload, you can infer it from SVR, not always exactly, but SVR is mean arterial pressure minus CVP over cardiac output. And the contractility is also important, which looks at, to a certain degree, by stroke volume. Delivery of oxygen is critical in the sense of looking at your SVO2 and your oxygen carrying capacity. So what do you see? What do you see in different kinds of situations? Let's look at a person who is in hypovolemic shock. In hypovolemic shock, you basically have somebody with low volume, so their preload is low, so CVP and PA occlusion pressure are both low, so they're significantly decreased. The SVR is also going to be increased because usually they get sympathetic overstimulation at that point, so SVR afterload is increasing, and the cardiac output is diminished because of the significant degree of preload reduction. As a consequence, you get an overall decrease in delivery, so your SVO2 actually falls. And that's usually an indication of hypovolemic shock. As for cardiogenic shock, usually the cardiac index is less than 2 liters per minute per meter squared. The PA occlusion must be greater than usually 17 to 20 millimeters for left ventricular cardiogenic shock, which then progresses pretty quickly. And what you see with left ventricular MIs is that you have an overall decrease in cardiac output, but you see a rise in PA occlusion pressures. The PA occlusion pressures are rising because you're getting MR regurgitation that's taking place and vascular congestion. So you get a PA occlusion pressure that rises. The SVR tends to increase because you get over sympathetic stimulation. And your CVP can actually be normal or increased depending on if it's developing right ventricular failure as well. If the CVP is normal, you could actually have isolated left ventricular failure. It won't stay that way for very long, but at least for temporary, in the initial presentation it may. But up to about 6 to 8 hours later, then the right ventricle starts to show signs of stress because the person is now developing pulmonary edema, and you'll see the CVP will rise at that point. So depending on which stage you pick it up. The SVO2 is going to be decreased as well because you have decreased cardiac output. If you have right ventricular MI, this person has a decreased cardiac output as well but the problem is not that the left ventricle is not pumping adequately, it's that its left ventricle just doesn't get enough preload. So as a consequence, most of the time PA occlusion pressure in right ventricular failure is actually dropped. It's actually lower than your CVP, which is one of the few states where CVP is actually higher than your PA occlusion pressure. Most of the time, PA occlusion pressure is 3 to 5 millimeters greater than the CVP. Okay? That should be the normal. But in this disease state, this PA occlusion pressure will be at the same level or slightly below the CVP. CVP will be higher than normal, so you should expect the CVP instead of 5, it actually should be around 10. Okay? And then your SVR will be also increased, and your SVO2 will also be diminished because cardiac output is diminished. Now, the next disease, which we'll talk about in the next hour, if we have enough time, which we may not have time, is decrease is pericardial tamponade. Tamponade is actually external compression of the heart. You'll see a PA occlusion pressure is actually high as well as CVP, but the actual volume in the ventricle is very low. So the LV EDV as well as the RV EDV are both very, very low. So volume inside the ventricle is low, but the actual pressures are very high. And I'll show you that in the next hour, the next 30 minutes if we get to it. Okay? SVO2 is decreased as well as cardiac output. If you have a PE, it's basically isolated right ventricular failure. So basically you get a low or normal PA occlusion pressure with a high CVP and decrease in cardiac output and decrease in SVO2. So this looks, a massive PE and a right ventricular heart attack basically look the same. It's very hard to differentiate. The way you figure it out is a lot of times it's acute. It's very, very rapid. And most of the time, massive PEs will get better quickly or you die. It's one of the two. You're going to get better within 15 minutes or you're going to die. Okay? Septic shock, I don't want you to memorize this. Instead, I want you to sort of think about it. It depends on the stage you're working at, so you get very confusing different symptomatologies for your cardiac output. It can go from normal to increase initially, then to decrease late. Usually that's a very, very bad sign. And the next one I'm going to talk about is anaphylaxis. This is a typical kid that will present with anaphylaxis. You can see the you'll see the actual lips begin to swell, okay? And you'll also get periorbital edema in these kids. You'll get the rash. We actually saw this yesterday on a woman. Not so profound. Instead, she started getting the rash, And one of the things that happens when you get anaphylaxis, what does the person usually present with? Cough. Okay? They start coughing. Okay? Why do they start coughing? They get acute pulmonary hypertension. Okay? Acute pulmonary hypertension. The rest of the body vasodilates, but the actual lung vasoconstricts. And they start getting a little bronchospasm as well. So you hear wheezing, and you'll see the person begin to cough. And that's how I picked up on it. Everybody's like, oh, it's just irritating, this cough. I said, no. I pulled down the sheet, and there she is, rash all over her body, red. It's like, okay, this is not completely anaphylaxis. So I said, we gave him a little Benadryl. As soon as we gave the Benadryl, the rash went away, the coughing stopped, everything stopped. Okay, so sometimes mild reactions can be treated with Benadryl, which is diphenhydramine, but most of the time, if you have profound anaphylaxis with shock, you need to get epinephrine. Epinephrine is the #1 drug of choice when you're into profound anaphylactic shock. Okay, and profound shock, I mean, it's just you literally the person will tell you that they're on fire. Okay, they will know that something bad's happening, and usually at that point they'll lose consciousness. And what's the most common cause of anaphylaxis in anesthesia? They're going to say muscle relaxants, which is pretty rare nowadays. It's mostly the antibiotics that we're giving. Okay, so I would say antibiotics would be pretty high on my list. Okay. This is the whole protocol to follow on how to actually deal with this. It's something I think you should review. This is something that I think when we do the sim lab, we're going to make you go through it. Make sure that you got the process of how do I deal with anaphylaxis, when should I give what drug. Epinephrine should be pretty high on my list, especially if the person's hypotensive, followed by high-dose steroids. Why high-dose steroids? It's not for immediately. It doesn't work. It works for 6 to 8 hours to shut down the mast cell degranulation, so it takes a while to work. Diphenhydramine sometimes is also used. The problem with diphenhydramine is it can cause vasodilation and can cause more profound shock. So I would not give that agent until I had a stable blood pressure. As for the last one to talk about, which is neurogenic shock, we will talk about this again in the coexisting next semester. This is just a sort of preemptive sort of discussion. It's basically an injury to the spinal cord, and you get inappropriate vasodilation because you knock out the sympathetic trunk in the thoracolumbar area. If you treat this inappropriately, you can induce a worsening problem, which is pulmonary edema in these individuals where you're given too much volume. So this is just inappropriate vasodilation. It has nothing to do with blood hemorrhaging. It just happens that all the blood vessels dilate at the same time. If you give them lots of crystalloids, you'll refill the tank, but what will happen is also you'll refill the lung tank as well. And the lungs will get heavy and the person will develop pulmonary edema and eventually go into respiratory failure, especially if they have quadriplegia. So one of the things that I would recommend is don't just give fluids, but give vasopressors early. Okay, the way we would do it is we'd put an A-line in these individuals and start them on levofed drips at low doses, just enough that we check the blood gases and make sure that they were getting acidotic. Usually our baseline blood pressure was 100, and that's all we gave them at. And then we gave them low volumes. And when we actually did that, we saw that almost 99% of these patients never got intubated. They just did fine without anything else, versus the people that were being resuscitated with lots of volumes, almost 100% of them got intubated within 24 hours. The work of breathing goes up so much from the increased volume, and the body has inability to reverse the shock initially for about 2 weeks. The good thing about a neurogenic shock within 2 weeks is the system reactivates and will control your blood pressure without needing anything else. So we can wean off the levofed in about a week and a half. You got to watch for acidosis because that indicates that you're squeezing them a little bit too tight. If you have hypovolemia like burns and crush injuries, you got to be very careful. You can lose large amounts of blood fluid and plasma volume from the burns. So you've got to replace that very aggressively. There's whole tables on that. We'll talk about this in trauma. And fluids, vasopressors, and treat the main cause always is a big thing. So we'll talk about this in more detail later.